Good evening everyone, and welcome to tonight's webinar. This webinar series is Getting to the Heart of Fertility, and tonight's webinar is titled PCO versus PCOS, What's the Difference? Myself, Dr. Amber Kennedy, and Associate Professor Martin Healey are going to answer all your questions on the topic. If you have questions, please submit them via the Vimeo app, or you can email them to newlife@newlifeivf.com.au, and we will try and answer them at the end. So first, what exactly is PCO? So PCO is actually an ultrasound definition, and this is a picture of a PCO, or a polycystic ovary. And sometimes we call it polycystic ovarian morphology, or PCOM. And what it means is that these fluid-filled structures on the ovary are there in numerous amounts, and the current definition is greater than 20 per ovary. We used to use a definition of greater than 12 per ovary, but since ultrasound machines have become more powerful and higher resolution, it is much easier to see these cystic structures on the ovary, and therefore you need to count more of them in order for it to be considered higher than normal. Now this is a picture of a cyst on the ovary, and the message I want to get across is that this is very different to the picture that we saw previously. An ovarian cyst is at least 3 centimetres in size, and it can be up to 10 or even greater centimetres. It can cause pain, they can bleed, they can rupture, and sometimes they need to be surgically removed. So these little fluid-filled structures are actually not cysts, and that's just a historical name, and they're actually follicles. And follicles contain eggs. And so what we probably should call it is polyfollicular ovary. Now this is a diagram representing the normal cycle that an egg goes through in order to mature leading up to ovulation. So eggs start off in a dormant stage where they are sitting there in reserve as part of your ovarian reserve. And once they get activated or recruited, they start to develop and create within the follicle, which is the supporting structure with cells and supporting the egg. They create this little cavity which is full of fluid. And in polycystic ovaries, this type of follicle is in numerous amounts. And so PCO, or polyfollicular ovary, is actually very normal in the first 8 years after your first period, i.e. when you're a teenager. And it actually persists in 20 to 50% of women, depending on what study you look at. Many women with PCO actually have normal cycles, and it may be associated with ovulatory dysfunction, or it might be completely normal. So compared to PCOS, what is PCOS? So PCOS is very different to simply having PCO on an ultrasound. PCOS is an array of symptoms: irregular periods, high testosterone, acne, excess hair growth, high cholesterol, diabetes, excess weight, lots of different symptoms that form a syndrome, PCOS or PCOS. And we actually now have very strict criteria for diagnosing PCOS. So first, you need to have PCO on the ultrasound. Second, you need to have oligomenorrhea, which means lack of periods, and we usually say less than 9 per year. Third, you need to have hyperandrogenism, and that means either symptoms of acne or excess hair, or hyperandrogenism proven on a blood test with high testosterone. Now actually this brings in a question that we've had pre-submitted, and I'm just going to read it out and answer it at the same time as I'm talking about this diagnostic criteria. So I have been told in the past that I have PCOS, and now my doctor tells me that I don't have it. Why is that? Actually, this is a really common scenario, and we acknowledge that it can be quite confusing and frustrating for patients not really knowing where they stand with regard to this diagnosis. And it usually represents one of 3 situations. 1, patients have been labelled incorrectly as having PCOS by just having PCO on an ultrasound, and that's not correct. Second, in the past we have had a diagnostic criteria which is slightly different, and that gets referred to as the Rotterdam criteria. And that meant that you only needed 2 of those 3 features of the syndrome in order to qualify as the condition. So in the past, you might have met the criteria for diagnosis just based on having 2 symptoms, PCO plus oligomenorrhea, for example. Whereas now that we require all 3, you don't meet the diagnostic criteria. And finally, the condition actually can vary throughout one's life, and I'm going to talk about that more in a sec. So what causes PCOS? Well, it's thought to be an underlying genetic tendency, and it may represent, or one sort of theory is that it may be because of a genetic difference in the LH receptor, which is a protein that responds to LH hormone. There are other theories as well. It might be to do with the estrogen production or testosterone production pathway in the ovary. But regardless of the any original reason, this underlying genetic tendency can't be changed. It's either there or it's not there. What can change and can affect the expression of the condition is other factors that develop throughout one's life. Taking age, for example, women who have this underlying genetic tendency, when they're younger, when they're in their early 20s, they may have very regular periods and not actually have much of the disease of polycystic ovary syndrome. And then they get older, and in their 30s they might stop ovulating regularly and they start expressing the condition. But then again, when they get to 40, it gets better again, and leading up to menopause they might actually have normal periods. Next, if we look at weight gain, we know weight gain is associated with PCOS, but it actually also makes you ovulate more infrequently. And that can lead to a greater hormone imbalance. And these factors can feed back on each other and make the condition better or worse with weight gain or weight loss. Equally, insulin resistance can also be related to the condition. So with weight gain, you might increase insulin resistance, which then makes the PCOS worse again. Okay, so now I'm going to hand over to Martin, who's going to talk about the different elements of PCOS in more detail.
Thank you very much, Amber. I'm Martin Healey, and what I'm going to cover initially is what does it mean and what do I have to do if I have PCOS? And here I'm not really talking about the fertility issues, I'm really talking about all the other things that come with PCOS. So this is again just repeating what Amber has said about the definition of polycystic ovarian syndrome, that you need a combination of evidence of either infrequent or not ovulating, raised androgens, and polycystic ovary appearance on ultrasound. So the first thing is, with this not ovulating regularly, what are the issues? And so the obvious issue is if you're wanting to get pregnant, there's trouble, and I'll come back to that a little later in the talk. The second thing, though, is that people get really frustrated with their bleeds. If their bleeds are infrequent, if they're unpredictable, that can really upset people and bother them. I think most of us like some things in our life to sort of follow a predictable pattern, and so there's an emotional frustration, irritation that comes with unpredictable bleeds, and that's the first thing that I'd really say with not ovulating regularly, that it can make your life a bit more chaotic. The second is, if you're not ovulating at all, when your ovary's working, it makes a hormone called estrogen, which causes the lining of your uterus or your endometrium to grow. When you ovulate, you release a hormone called progesterone, which matures that lining. If you don't ovulate, you don't release that progesterone. And estrogen by itself over long periods of time can lead to precancerous and even more rarely cancerous change of the endometrium. And so not ovulating at all can carry with it an increased risk of precancer and cancer of the endometrium. And so that's something that we're aware of as doctors. And so if we see patients who have PCOS and they've got an irregular cycle or infrequent periods, we will often be recommending that they go onto some form of progesterone hormone to protect against that risk. And this comes in sort of a few quite common forms. The first is to put people on the combined pill. The second would be to give them a progesterone-only tablet that they take on a regular basis. And then the third would be to put in what's called a Mirena IUD, which is an IUD that is releasing progesterone locally to the endometrium on a continuous basis. What about this raised androgens or raised testosterone? What we see with that is a variety of situations, but the common things people complain of is increased pimples, sometimes in some unusual places, increased hairiness, particularly sort of extra hairs around the nipples or a snail trail going down from the belly button downwards, sometimes increased hair on the jawline or on the arms. And then sort of in a semi-contradictory way, increased hair loss off the scalp. What can we do about this? So there's some really simple things that people do frequently. So for pimples, patients will often go and see their dermatologist, who may give them various creams or may put them on antibiotics. For the increased hairiness, people do, again, a range of things, including plucking, waxing, dissolving the hairs with various agents, and shaving, and even laser surgery for it. It's kind of hard with the increased hair loss to put the hair back on the scalp, but again, you can have surgery to do that, and there are clinics to do that. The other direction that as gynecologists we go in is to try and change the hormones around. So if the issue is that relatively there's too much testosterone in the system, what we try and do is reverse that by either getting rid of the testosterone in the system or putting in something to compete. And so the simplest thing is that we put people on the combined contraceptive pill, and the estrogen in the pill causes a chemical to be released into the bloodstream which mops up testosterone and means that there's less testosterone available in the bloodstream to cause trouble. And that chemical's called sex hormone binding globulin. The other thing we can do is put people on anti-testosterone medications which will basically compete with any testosterone and therefore reduce the effect of testosterone. And there are some forms of the combined pill that have small amounts of this anti-testosterone in it. And then you can also get these anti-testosterones in much higher dose for people where, say, putting them on the combined pill isn't having much of an effect. It's worth saying that with hair growth, it takes time to see benefits. So if we use drugs to help with it, that what we'll generally be looking at is really minimum of 3 and probably 6 months before we can be confidently saying, yes, this is helping, or no, it's not. The third thing which we are becoming increasingly aware of with polycystic ovary syndrome as time goes by is all the metabolic sort of implications of it. The first is that when we look at women with polycystic ovary syndrome, it really can be broken up into two groups: the women who are overweight and the women who aren't. And we see a significant group who are overweight. That's about sort of 4 out of 5 women with PCOS. And so we need to be thinking, well, women are overweight and sometimes very overweight, obese, or even morbidly obese. What can we do about it? And for anyone who's tried to lose weight, there's a heap of things that you can be advised about. And so the common sorts of advice people will be given is, change your diet, healthy diet, exercise more. Less common things, people talk about putting you on a drug called metformin, which is an anti-diabetic drug. And then less common again is bariatric surgery. So looking at surgery to actually do something to the stomach to either reduce the amount that you eat or reduce absorption or something like that. And all of these are reasonable things to consider, but they need to be discussed together with your GP, who will give you sort of more insight into this. The second sort of issue that comes with polycystic ovarian syndrome is, as mentioned earlier by Amber, that people with PCOS have an increased risk of developing diabetes or type 2 diabetes. And so there's often women with PCOS will have insulin resistance or hyperinsulinemia. And so with regards to that group are the group who are particularly likely to benefit from going on to anti-diabetic drugs such as metformin. The third thing which we tend not to think about but comes with obesity is fatty liver disease. And so you can end up with chronic liver disease from secondary to developing a fatty liver with obesity. And this is, I think, a hidden thing that people don't realise until quite late, but may well come back to be an issue later in life. I've mentioned diabetes already, and so diabetes is a common condition that comes on in women with PCOS later in life. Not everyone with PCOS gets diabetes, but certainly the risk is higher, and so we would regularly we would recommend that women regularly have their blood sugars checked at least on an every second year basis. Finally, cholesterol. There's an increased risk of having raised cholesterol with PCOS, and so this is something that, again, should be tested for on a regular basis, and if it does become abnormal, it should be treated. Increasingly, we're aware with PCOS that there can be mental health issues. So there's an increased risk of anxiety, increased risk of depression, and particularly with people who are overweight, low self-esteem or increased hair growth, low body satisfaction. With the overweight issues come also people trying to sort of combat that with eating disorders. So we can see an increased risk of bulimia in particular in this group. So the message is to say that with PCOS, be aware that if you have it, that it's worth, again, just touching base with your GP about sort of are there signs of any other issues going on with regards to mental health. And I think that the taboos of mental health are gradually fading in society, and so it's increasingly something that you should bring up and actually ask the question both of yourself and of your GP. You know, is anything like this going on with me? I've got PCOS and I've been told that these things are a higher risk. Can you please keep an eye on me for them? Sexual function, again, sort of segues in from the mental health issues, that lower sexual satisfaction, lower orgasm scores are all pointing towards people with PCOS having issues in this area. And these areas, unfortunately, are still probably more taboo than mental health in general. But yeah, what you should be hearing is it's worth asking the question, is there something that can be done for this? Because often with a bit of help, things can be improved in this area. The final thing is, you know, we're a group of people who do IVF, so what about pregnancy? And in pregnancy, if you've got PCOS, you're at a higher risk of getting gestational diabetes or diabetes in pregnancy. You're at a higher risk of getting blood pressure issues, and specifically preeclampsia. And with this, there is also a bit of a genetic sort of longitudinal issue, which is to say that if you have PCOS, if you have daughters, they've got a higher risk of having PCOS than the general population. So the take-home message, if you've got PCOS, get a good GP and make sure that you're being monitored, that you're seeing your GP regularly, and that the whole sort of gamut of things that come as sort of baggage with PCOS are being watched by your GP and monitored for. There's a lot that can be done, and the take-home message is that with effort, a lot of the sort of limiting issues that PCOS apply to your life can be reduced and to give you a better quality of life. I'm going to hand over to Amber at this point, and she's going to discuss, does PCOS make you infertile?
Okay, so a burning question, does PCOS make you infertile? So the simple answer is no, but also yes, which is not very simple, I admit. Essentially, the single biggest way PCOS affects your fertility is by decreasing the regularity and the frequency of you ovulating. And in order to conceive without assistance, you really need to be having regular periods, and that means be ovulating. Additionally, as we've talked about, PCOS has associations with excess weight and also diabetes. And both of these factors can both make it more difficult to fall pregnant in the first place, but also increase the risk of miscarriage and also pregnancy complications like gestational diabetes, like Martin mentioned. So how do you know if you are ovulating or not? Well, the simple answer is that if you're having regular periods, then that means you are ovulating. A period is the result of an ovulation event occurring approximately 14 days prior and then not falling pregnant, and so a period comes. So if you're having predictable periods that are coming roughly every month, then they're most certainly ovulating. So how do you know when you are ovulating? So if you are having a regular 28-day cycle, that means roughly you are ovulating on day 14. And if you're trying to fall pregnant, we would recommend trying to time intercourse around that fertile window, which means approximately second daily intercourse from day 11, so let's say day 11, 13, 15. If you have a slightly shorter cycle, which sometimes we do see in women with milder PCOS, then you may want to time intercourse slightly earlier in the cycle because you probably ovulate around day 11. If you are having an irregular cycle, it does start to get a bit trickier. So let's just say your period can come anytime between 25 days to 32 or even longer, up to 35 days. Then it's a much wider potential fertile window, or the ovulation could occur anywhere from day 11 up to day 21 if you were talking about a 35-day cycle. So some women use what's called an ovulation prediction kit or an LH test strip. And the way this works is that LH is a hormone that is throughout most of the menstrual cycle at baseline levels, usually less than 5. Just prior to ovulation, we see here in a 28-day cycle around about day 14, there's a sudden rapid increase in detectable LH levels. And LH detection kits, they're a urine dipstick which detects LH hormone in the urine, and they will come up as positive, denoted here by the 2 lines, if the LH level is above 20. And usually that means that it is signifying ovulation. However, in women that have PCOS, we do not recommend these test strips because they have usually a very high baseline LH level, and that means that the LH strip will be positive at times not associated with ovulation, and you'll get led astray by that test kit. Actually, this brings us to another question that we had that we get from patients often and we've had submitted, which says, I've been told not to use LH OPK or ovulation prediction kits as I have PCOS. What cycle tracking can I use? So yes, that's right. Like I said, it's not recommended to use LH strips if you have PCOS. The methods that are probably the most reliable is just tracking your cycle, knowing what your cycle range is, so the calendar method, it's traditionally called. And if you're having cycle length up to about 35 days, then this, even if it's irregular, it can be feasible to time intercourse to that even varying fertile window. Some women use what's called a basal body temperature chart, and that means testing your temperature first thing in the morning, before you get out of bed, before you have a drink of water. You have to use a very accurate thermometer, and what we see is that after ovulation, the body temperature rises by about 0.5 degree. And the reason for that is that progesterone hormone, which is a hormone released only after ovulation, which you can see here in the pink colour, that is thermogenic, so that raises our body temperature. This can be a benefit if you have a varying cycle, and because it can tell you that ovulation has already occurred and you can stop timing intercourse. It is limited in that it doesn't predict ovulation is going to occur in the next few days. It's only after the fact, but some women do find this useful. And then finally, if you have cycles that are longer than 35 days in length, it becomes pretty unfeasible to track the cycle and to try and work out when you're ovulating. And in that case, we would usually recommend some kind of fertility assistance, whether that would be ovulation induction or other treatments that Martin is going to talk about.
Thank you, Amber. So, what things can you do to help you get a baby? So you're wanting to get pregnant, you've got PCOS, and you're told by your GP or your specialist you're going to have trouble and it looks like you're not ovulating, or it's very hard to predict when you're ovulating. And so I think let's start really simple. There are lifestyle things you can do. Now, this isn't true for everyone, so this is true in particular for people who are overweight. So if you've got PCOS and you've got a normal weight, me telling you to lose weight is silly because it's not going to do anything. But if you're significantly overweight or obese, then there is good evidence that just purely by losing weight, you will get a percentage of people swinging away from not ovulating to ovulating, or swinging from an irregular cycle to a regular cycle. The second thing you can do is a process called ovulation induction. And so with ovulation induction, what we're aiming to do is we're trying to drive your ovaries to release eggs where currently they're not doing it. And so we use one of a number of drugs to do this. And so probably the most well-known drug in the community currently is a drug called Clomid or Clomiphene. This has kind of been replaced in recent years by a drug called letrozole, which is thought to give you probably a little bit of a better ovulation rate and a little bit of a better pregnancy rate. With both of these drugs, they're taken in a cyclical basis, so you have your period and then you start taking the tablets, usually day 3 for 5 days, so day 3, 4, 5, 6, 7, or some people will do it day 2, 3, 4, 5, 6, or day 5, 6, 7, 8, 9. There's a variety of different ways people do it, and none of the sort of variations really seem to have an impact on success rate. The dose we use will vary from person to person, and so we usually will start on a low dose, see if you ovulate, and then if you don't, the next cycle we'll put the dose up and keep on doing so until we either get you to a stage where you're ovulating or we get to a maximum dose and you're still not ovulating. If you have evidence of insulin resistance, then there is the potential here to add in metformin as well as the drugs for ovulation induction. And so metformin seems to have a particular benefit in the group of women with insulin resistance to make them more sensitive to the ovulation induction drugs. If you don't respond to drugs like letrozole or clomiphene, what do we do then? And the answer is we then get a bit more, I'll use the term aggressive, and that is that we start giving you the drug as the hormone that as a drug that you would normally produce yourself to cause ovulation. That's a drug called FSH. And so we get you to start taking injections of this, and we can basically increase the dose as needed until we get you to a stage where you are ovulating. The next thing we can do is to try and do something on top of that. But it's worth saying that with ovulation induction, we'll probably get about 70% of people ovulating, and of that group, 60 to 70% will achieve pregnancy just with the simple medications I've talked about. If that's not working, the next thing we'll do usually is start doing some extra tests. And here we're starting to look and see, is there something else going on? You know, do you have blocked tubes? Is your partner shooting blanks? Is there something else that's interfering with you getting pregnant? And if all of that's coming back saying, no, everything's looking fine, then we can give you a better chance of getting pregnant by doing a process called artificial insemination. And this involves basically taking your partner's sperm, filtering it and getting the best sperm out of it, and then actually putting a little catheter up through your cervix into your uterus and injecting the sperm into your uterus just before you ovulate. And this is all about increasing the, if you like the term risk, or the chance of you getting pregnant. So if you've tried ovulation induction for about 4 to 6 cycles and you're not pregnant, you're getting down to probably a 2 to 3% chance per cycle of getting pregnant with further just straight ovulation induction cycles. If we add in the process of artificial insemination, on average you're bringing your chance of pregnancy probably back up to around about 10 to 15%, and that will vary depending on your age. So the older you are, the lower the success rate, the younger you are, the higher the success rate. The final option we've got is to do IVF, and IVF is a process where we basically will stimulate you not to produce 1 egg or 2 eggs, but to produce lots of eggs. bring you into hospital and collect those eggs, get your partner to provide a sperm sample, fertilise the eggs in the laboratory, and then 5 days later put one of the embryos back into you to try and achieve pregnancy. So, does everyone need IVF? And the answer is no. What you're hearing is that a lot of the other treatments do get people pregnant, and so IVF is one of those things that everyone's heard about, but it is a less common rather than a more common treatment for women with PCOS. And it's only, if you look at women with PCOS who are not ovulating, maybe half or less will need IVF. So why would you need IVF? I've already mentioned blocked tubes, your partner having abnormal sperm, not success with doing ovulation already, or occasionally we'll get people who are sort of either all or nothing. So they either don't ovulate, or when they do ovulate, they'll release 5 or 6 eggs all at the same time. And we're very uncomfortable with having people doing either artificial insemination or ovulation induction in the standard way there, because the risk of them ending up with twins, triplets, or higher multiples of pregnancy goes up quite significantly, and that becomes a situation where there's danger both to the woman getting pregnant and also higher risk to the babies. So I've already mentioned sort of the simple process of IVF. IVF, however, in women with PCOS is not without risks. It's got a good risk in that women tend to get lots of eggs. They've got lots of follicles, and so when we stimulate them, they produce lots of eggs. But if a woman produces too many eggs, so if she's producing sort of in the 18, 20, 25, 30 plus eggs in a stimulation cycle, she's at risk of getting sick. And there's a condition called ovarian hyperstimulation syndrome, which can occur in women having IVF, and which is something that is a higher risk in women who have PCOS. Now, a question that came in earlier is, does having PCOS mean I will always have a high chance of OHSS with IVF? And the answer is you have a higher chance, but it's still not high. So if we look at all comers having IVF, you're probably looking at about a 1 in 200 risk of developing ovarian hyperstimulation. Adding on top of that PCOS, and you might get that up from a 1 in 200 to a 2%, so maybe a 1 in 50. You might get up a little higher than that, but it's still the vast majority of women with PCOS do not develop ovarian hyperstimulation. So what's the success rate if I do IVF and I've got PCOS? And the answer is it's usually average or a little bit higher. But there is a caveat on that. And just looking at this graph that I've put on, what we see in all women who have PCO, who have IVF, is that as their BMI or their weight goes up, the success rate of IVF goes down. So you're starting out with an average of around 31%, and that gradually drifts down, so that when you're looking at women whose BMIs are over 50, their chance of getting pregnant and having a baby per cycle has dropped down to around about 20%. If you look at the darker line though, women with PCOS overall have a better chance of getting pregnant. So you're talking about rates as high as 44% live birth rates, but the drop is more impressive and faster as the BMI goes up. And so both having PCOS and BMI are working sort of in a combined way in women with PCOS to mean that the higher the weight, the more the impact in reducing your chance of success and live birth rate. Now, I've talked about this ovarian hyperstimulation syndrome. What actually is it? So this is a condition where a woman produces lots of eggs all at once, and the ovaries start to actually leak fluid out of them. And this fluid comes out of the blood that's going through the ovaries and leaks into the space around the ovaries and your loops of bowel and the uterus. It's coming out of the bloodstream, so the blood in the bloodstream becomes thicker, and with that comes a increased risk of blood clots in the lungs and in blood vessels. It also means that there's less blood going around to your kidneys and liver, and so women can start getting problems with their kidneys and liver and can get very sick and rarely die. We worry about this condition, so we watch out for it very carefully, and if we are suspicious that someone has ovarian hyperstimulation, then we're likely to say stop the cycle, or at very least change the type of maturing drug we use to mature the eggs and not put back an embryo in that cycle, because if you get pregnant and you have ovarian hyperstimulation, you tend to get a lot sicker. So if you're wanting to have IVF and you've got PCOS, what are the sort of the take-home messages? The first is anything you can do to lose weight before you start is a good thing. And that may actually save you needing to have IVF if it moves you from not ovulating to ovulating in some cases. The second thing, which is more an issue from your fertility specialist side, is that we have a tendency, a very strong tendency in women with PCOS to use what's called an antagonist protocol. And so one of the drugs we use is a newer drug called an antagonist. Previously, we would use what's called an agonist to try and prevent the ovaries from releasing eggs when we don't want them to. By using an antagonist, it allows us to use a different sort of trigger when we want to mature the eggs, and with that different sort of trigger, it almost always, not always, but almost always reverses the ovarian hyperstimulation process. The sort of the negative of using that trigger, however, is that it also interferes with the endometrium and makes it very unlikely that you'll be able to get pregnant by putting an embryo back in that cycle. And so what we do is we change the trigger and go ahead, collect eggs, fertilise them, grow them, but then we freeze them all and wait a couple of cycles before we go ahead and put an embryo back. The final thing we do is we get a little bit more cautious, and so with the stimulation drug we use, FSH, to produce lots of eggs, we start with a lower dose of that so as to try and avoid you developing this condition in the first place. So that's really the end of our sort of discussion on the PCOS and PCO, and I think it's really a case now of dealing with any questions you have. And there are a couple of questions that I didn't discuss earlier, and my apologies, but they did come in earlier. And the first is, does having PCOS mean I'll have more immature eggs collected during IVF? And the answer there is sometimes yes, but not always. That women with PCOS, particularly if they produce lots of eggs, that the rate of immature to mature eggs does go up a little bit. Still, the majority of eggs will be mature, but the proportion that are immature does go up a little bit. And we also see that women who have produced a lot of eggs don't get quite as good a pregnancy rate as time goes by. That there seems to be a sort of a perfect middle ground, which is sort of in the region of 10 to 20 eggs is great. When you go over 20, pregnancy rates seem to drift down a bit. When you don't have as many eggs to work with, under 10, pregnancy rates drift down a bit. The other question is, how do you treat patients with PCOS undergoing IVF treatments at New Life IVF? And I think this question, I'll refer back to what we've already discussed, and that is we approach them individually. We talk about the things that we've already gone through, which is lifestyle, but when it comes to IVF treatment, what we're trying to do is minimise risk while still trying to maximise the chance of getting pregnant. Do we have any other questions? We do. And so I'll hand over to Amber and she'll answer some more questions and we will keep on going.
Thanks, Martin. So we do have a few questions. Keep sending them in if you still have some. So the first question that I have is, can PCOS go away? So like I mentioned about that underlying genetic tendency towards PCOS, that doesn't go away, your genes can't change. However, you can alter the expression of the condition, and that can happen on its own with age. As I mentioned, women as they get older, they can go back to having regular cycles, and we think that that's because the total ovarian reserve is decreasing, so the follicle number is decreasing, and so then the expression of the condition reduces and ovulation becomes more regular. Additionally, if you're able to be successful in weight loss endeavours and lifestyle management, sometimes even 5% loss of weight in your total body weight can result in resumption of spontaneous ovulation and periods, and then the condition can settle down quite significantly. So it doesn't go away completely, but it certainly can quieten or be quiescent temporarily.
Next question is, I have PCOS. What is the best age to get pregnant? And this is a curly one. So genetically, the best age to get pregnant is around 25. Okay, so how many people actually want to get pregnant at 25? Nowadays, in today's society, not very many. So if you're 25 and you're desperately wanting to get pregnant now and you're in a stable relationship and it all works, then that's brilliant. Go for it. Okay, but if you're in a situation where it's not going to be till you're 30 or 32 or 33, then your fertility is still very good at those sorts of ages. Once you get over 35, as fertility specialists, we start to frown a little bit and say, well, you'd better get on with things, get moving, because the quality of your eggs is going downhill. Okay? But from the point of view of PCOS, as a generalisation, you're probably going to be having more eggs than average, and so you're going to be a patient that we're going to be happier to treat rather than someone who's got hardly any eggs. So take home message, younger if it fits with your life, but that doesn't mean you're 25, you've got no partner, you're desperate to progress your career and you've got to give up your career and run off and get pregnant tomorrow. That would be absolutely silly. So it's within the constraints of your life.
All right, so next question. I've always had regular periods, 28 days in length. Last 3 cycles, 70 plus days. Do I now have PCOS? I have 70 plus follicles and acne. Well, without taking a full history and seeing you and talking about what's going on, and being very simplistically looking at your symptoms and the diagnostic criteria, you do meet all of those different symptoms. So having irregular periods, 70 days in length, would certainly qualify as oligomenorrhea. Having 70 plus follicles certainly qualifies as polycystic ovary morphology on ultrasound. And acne is symptomatic hyperandrogenism. So simply based on that, even using the more recent strict criteria, yes, you do qualify as having PCOS. So of course I would encourage you to speak to your GP and have a more in-depth discussion about that.
It's worth saying with that part of the reason for speaking to your GP is that PCOS is a diagnosis of exclusion, and so although it's quite uncommon, every now and then we'll see someone with a thyroid problem or a raised level of a hormone called prolactin or problems with their adrenal that can mimic PCOS, and so we like to exclude those as part of it, and that's why I think Amber is sort of hedging and sort of saying, well, you probably do, but, and that is that you really need those things excluded first. The next question I've got is, what is the best treatment for PCOS? And that's kind of a crazy question because there is no best treatment. There's lots of different treatments and we've talked about them, and they have to be individualised because people with PCOS are so different. If you're thin and you've got acne, no increase in hair, and you've got a regular cycle, then it may be as simple as using some cream for your acne, and that's it. If you're thin and you're not ovulating, but you've got no acne, but someone does your blood test and finds that your testosterone's a little bit raised, then you may need drugs to help you ovulate, and that's it. So it varies depending on the individual scenario. There isn't one simple, here, take this tablet, this is the best tablet, and this will all fix you. And it also is very much dependent on what it is you're talking about. And as I mentioned earlier, there's a whole bunch of stuff with PCOS that isn't fertility related that has to be looked after. And so this is a sort of no one answer fits all.
The next one is, what diet is best for PCOS? Well, a general healthy diet, low GI, is certainly better than a high sugar diet. So refined sugars are not good for anyone, but particularly in women who have PCOS and who may be at risk of developing insulin resistance. So I would recommend seeing a dietitian, and that's certainly what we do routinely for women who have a new diagnosis of PCOS, is we get a dietitian involved as they're experts in all nutrition and diet advice.
Okay. The next question I have, I've kind of answered before, and that is, does having PCOS mean I always have a high chance of having OHSS? And the answer to that is no, you have a higher chance, but it is still a low chance. And within people with PCOS, there are some people who seem to be a little more prone than others. And for those individuals, your doctor is likely to say, look, you're someone we might worry about this a bit more for. Whereas others, you'll find they're quite relaxed and not really talking about it as though it's a big drama. So I think that's something that you should bounce off the vibes your doctor's giving you as to how much you should worry about that, because it's something that it's easy to worry about, but where what you're hearing me saying is you're talking about maybe 1 in 50 women with PCOS are going to get it. It's not something that most people end up getting.
Great. I think that's all the questions that we have. Thank you. This video will be available on YouTube afterwards if you're wanting to review any of it, if you've missed anything. And for making appointments to see one of us or any of the specialists at New Life IVF, you can go to newlifeivf.com.au or email us at newlifeivf.com.au.